Acute arterial occlusion can occur in any peripheral artery of the upper and lower extremities. This can lead to a limb or life-threatening ischemia. In pathophysiology, acute limb ischemia results from a lack of blood supply to meet tissue oxygen and nutrient requirement. As time proceeds, cell death or irreversible tissue damage can occur. Peripheral nerves and skeletal muscles are more sensitive to ischemia, and hence irreversible changes occur in these tissues within 6 hours. So these are the most common disorders which are associated with which can lead to arterial occlusion, as in thrombus, embolism, catheterization complication, trash photo-Bluetooth syndrome, Raynaud's disease, TAO, HIV, arthritis, etc. In all these conditions, management depends on the etiology. As in thrombus, it can be medical or interventional management. In case of embolism, embolectomy can be done, and preventive anticoagulation should be done. In catheterization complication, it can be either conservative or operative repair. So all these conditions, the management depends on the etiology. So coming into detail, thrombosis is the most common cause of acute limb ischemia, and it is the more than 80% cases of the lower limb ischemia is due to thrombosis. So this non-embolic limb ischemia is mostly secondary due to atherosclerosis. So the plaque rupture, atherosclerotic plaque rupture, can cause complete or high-grade occlusion, which will obstruct the flow completely and then trigger symptoms. But in most of the cases, ischemia presents as chronic occlusion that can be clinically mute depending upon collateral network instead of complete occlusion. So in thrombosis, the other mechanisms other than plaque rupture, the ischemic injury can be progressed through all these mechanisms also, as in the clot can propagate and occlude collateral vessels, ischemia-related distal edema, which can lead to high compartment pressure, as in compartment syndrome. The clot can fragment and enter into microcirculation and edema of the microvasculature cells. The second most common cause of arterial occlusion is embolism, which is less common than thrombosis. Most of the cases of embolic arterial occlusion are due to the decrease in, the less common occurrence of embolism than thrombosis is mostly due to the decline of rheumatic heart disease and treatment of AF with anticoagulants. The site of origin for embolus is usually heart, and in most common site is left atrial appendage after atrial fibrillation, and the second most common site is mural thrombus after recent MI. So both MI and AF can trigger embolic arterial occlusion. The other non-cardiac sources of embolic arterial occlusion is aneurysm and atherosclerotic plaques. Mural thrombi in aneurysm of aortoiliac, femoral or popliteal and subclavian arteries can also cause embolic arterial occlusion. These atheroemboli result from plaque fragmentation and can cause obstruction of the microcirculation and produce symptoms in the hands, feet, which is known as Bluetooth syndrome. It can also cause symptoms by obstruction of cerebral circulation, as in transient ischemia. Also, paradoxical embolization can occur when there is a venous clot which passes from right to left side of the heart through an intracardiac shunt, most commonly a patent foramen ovale. The other causes of arterial occlusion are intentional or accidental intraarterial drug injection by either a medical personnel or IV drug abuser. This can result in vasospasm, infectious arthritis, thrombosis, pseudoaneurysm, and mycotic aneurysm. Also, in the inert drug particles or drug crystals can cause embolization and result in gangrene of the digits. Prolonged use of vasopressors can also result in arterial occlusion. And And the other non-embolic central causes are thoracic aortic dissection, which can propagate to subclavian and iliofemoral systems. Most clinical features, coming to the clinical features, the 6 Ps are the most common, or the patients with acute limb ischemia can present with either one or all 6 symptoms, as in pain, pallor, paralysis, pulselessness, paresthesia, and polar, to signify the cold and clammy extremities. So, in these patients, the 2-point discrimination, the vibratory sensation, proprioception, all the deep sensations are often diminished. And an abrupt loss of a previously strong pulse is also suggestive of acute embolization. In acute limb ischemia, the symptoms usually start within a 2-week duration. And from history, there is a sudden severe pain over the foot, which will wake the patient during his sleep. Also, when the patient will describe it as he'll find comfort when he hangs the leg down from the bed. And depending upon the site of pain, we can identify which artery is involved. If the claudication, the pain site is in buttocks, thighs, and sometimes calf muscles, it can be the occlusion is in iliac artery. If the site is in thigh, it can be common femoral artery. Upper 2/3 of calf, pain occurs in superficial femoral artery occlusion. Lower 1/3, if the pain is in lower 1/3, it can be popliteal artery occlusion. If the pain is in foot, it can be infrapopliteal artery occlusion. So this is Rutherford criteria for acute limb ischemia to know the severity of arterial occlusion. If in Doppler, both arterial and venous signals are audible, and if there is no sensory loss or muscle weakness, it is considered as category 1 or viable. There is no immediate threat. Whereas if arterial signals is inaudible and venous signal is audible, it comes under threatened, category 2 or threatened viability. There, if sensory loss is minimal or none and there is no muscle weakness, then it is the limb is salvageable if promptly treated. So that is considered as 2A, that is marginally threatened. And if more than toes, if the sensory loss is present in more than toes associated with rest pain, and there is mild to moderate muscle weakness, it is salvageable with immediate revascularization. So it is considered to be immediately threatened category. If the arterial and venous signal are inaudible and there is profound sensory loss and profound muscle weakness, it comes under major tissue loss or permanent damage, and it is category 3 or irreversible limb ischemia. So in diagnosis, the handheld Doppler to detect the presence and absence of blood flow and its amplitude can be used. Also, ankle brachial index can also help. Ankle brachial index is the systolic blood pressure with the cuff just above the malleolus with the Doppler probe over the posterior tibial or dorsalis pedis artery and the highest brachial pressure in either arm. Here you can see both right and left arm systolic pressure is calculated, and then the right ankle systolic pressure is calculated with both dorsalis pedis and posterior tibial. So to calculate the right ankle brachial index, higher right ankle pressure, whichever is higher in dorsalis pedis and posterior tibial, is calculated, and that is divided by whichever arm pressure is the higher, right or left arm systolic pressure is higher. So if the ankle brachial index is more than 1.3, it is not compressible. 0.91 to 1.3, it is normal. 0.41 to 0.9, it is mild to moderate peripheral arterial disease. 0 to 0.4, it is severe peripheral arterial disease. So for lab evaluation, the markers we send are markers of cellular death, creatine kinase, myoglobin and lactate, To see the metabolic status, electrolytes and glucose are sent. Renal function can be assessed to note the reperfusion injury, as in blood urea nitrogen, creatinine urine analysis. CBC should be sent to check for infections, bleeding tendencies, PT and APTT done to see for bleeding tendencies. ECG should also be sent. Imaging, the most common modality used is duplex ultrasound. Transthoracic and transesophageal echo can give an idea in aortic dissection. Arteriography can assess the flow and the amplitude in the vessels. CT with contrast is the easily available imaging modality in ED. Also, MRI also can be done. In management, the main objective of management is restoration of blood flow to preserve limb and life and prevention of recurrent thrombus or embolism. So the most common medical therapy which is given in ED is unfractioned heparin. The dosage is 80 units per kg bolus, followed by infusion of 18 units per kg per hour. Also, aspirin start dose of 325 milligram can be given and 82 mg daily after that to prevent the recurrence. Also, symptomatic management and pain control and the environment protection to protect the ischemic limb from temperature extremes. So in detail, category 1 and 2A will need diagnostic image workup prior to the definitive management, whereas category 2B needs immediate revascularization without additional imaging once you're diagnosed. Category 3 is irreversible damage and it will require amputation. So for definitive management, it can either be done with catheter-directed thrombolysis, percutaneous mechanical thrombectomy, if there is any occluded bypass graft which caused the embolization, which can be pre-visited to correct the whatever the occlusion, and revascularization can be done with either PTA or standard surgery. So in case of long-term surgical management, as in TAO, we know that it's mostly mostly seen in smokers. So smoking cessation, exercise, and pharmacotherapy, as in daily aspirin, anticoagulants, other lowering cholesterol and BP, and improving the glycemic control can be done. Thank you.
Okay, Nadia, it was a good presentation.
Thank you, sir.
Some points was missing. Anyway, it's actually very, very important topic, especially in the current scenario, because in this COVID era, we are getting numerous cases with presenting with acute limb ischemia. Some patient present as acute limb ischemia, and when we do a COVID PCR test, he will be positive, and also numerous post-COVID complications presenting as venous and arterial thrombus, like that. So in coming future, you will get numerous cases. In the ED also, we got many cases with acute limb ischemia. So it is actually diagnosis is a very must, because it is a limb threatening situation. So if you miss a diagnosis of acute limb ischemia, it may result in the in limb loss. So that is a grievous injury, so that you should never miss an acute limb ischemia. Recently, I can tell you a case which presented to our ED almost 1 month back, who was referred from outside peripheral hospital. Some old age lady. She was referred with what pain in the left upper limb, upper arm, in the arm, and ECG was taken from outside. She recently had an AF and started on anticoagulation. So that patient ECG was normal, and when they checked, INR was elevated. It was around 7. So they referred with coagulopathy. But in our ED, when we checked, there was a radial delay. And we sent the patient for Doppler ultrasound, and which showed an arterial occlusion. And we started on an apparent bolus and infusion, and was shifted to cardiac side. So, like that, uh, you may get numerous cases recently. Uh, so within 4 to 6 hours, you have to make a diagnosis, and if it is a Rutherford class 2B, or 2A, 2B, immediate revascularization may be required, and you have to do things accordingly. And most of the cases are thrombotic events, and in some cases maybe embolic events. So there might be some. It will be very difficult to differentiate between with the clinical presentation whether it is a thrombotic or embolic, but still some clinical features may be present. Like if it is an embolic event, there may not be an history of claudication pain, or and in the then you can easily identify the source. If it is an embolic one, probably the patient may be having any atrial fibrillation or any cardiac disease like that, previous MI or maybe present. And on physical examination, the opposite limb may be normal, and usually an embolic occlusion present at acute onset of uh, limb pain. Nadia mentioned that the onset is within 2 weeks, but usually that case is the thrombotic event. But in case of embolic event, there may be a sudden acute onset of limb pain. And in the radiology case, there will be a sudden abrupt cutoff in the blood flow and there will be no collateral, usually no collateral circulation, and the minimal disease vessel in case of embolic event. Whereas in the thrombotic event, you can usual presentation like there will be claudication pain, and there will be marked signs of occlusive arterial disease bilaterally, like color changes in the skin, pulses will be deficit, vasospasm will be present, and usually source cannot be identified, and usually it is a gradual in onset, and radiologically there will be widespread disease with collaterals present. There will be collateral circulation, and the gradual narrowing of the blood flow will be seen. So like that, and timing is very important. Immediately you have to make a diagnosis, and classify accordingly with the Rutherford criteria 1, 2A, 2B, and 3. And artery, meanwhile, you can identify with the presentation, and the clinical claudication site. Already Nadia has mentioned that. And in the treatment part, mainly in the ED, we usually use to use the unfractionated heparin, 80 units per kg bolus, followed by infusion. And in thrombolysis, IV thrombolysis can be done, and but usually we do intra-arterial thrombolysis, direct intra-arterial thrombolysis. And the main complication after the treatment is the reperfusion injury. Like as the more the time, the more chance for reperfusion injury and the severity of reperfusion injury. Because as more the time, there will be more reactive oxygen species into the circulation, and more chance for myocardial injury and death. So that is the main complication after the revascularization of this in case of acute limb ischemia. So that's all. And so it's a very, very important topic. You will come across with many cases of acute limb ischemia in the future, after, especially after this COVID era. Okay, thank you, Venu sir.
ഇവരൊന്നുമില്ല ഫൈസല്. പിന്നെ ഇവര് പിന്നെ ഹാങ്കിൾ ബ്രാക്കിയൽ ഇൻഡെക്സ് ഒക്കെ പറഞ്ഞിട്ടുണ്ടായിരുന്നു.
ആ സർ പറഞ്ഞിട്ടുണ്ടായിരുന്നു.
പറഞ്ഞിട്ടുണ്ടായിരുന്നു. യൂഷ്വലി ഇവർക്ക് പരീക്ഷയ്ക്ക് ഒരു ക്വസ്റ്റ്യൻ ആണത്. പിന്നെ യൂഷ്വലി പാർട്ട് എയിലും ബിയിലും സിയിലൊക്കെ വരുന്ന ഒരു ക്വസ്റ്റ്യൻ. As you have mentioned, we are in an era with a lot of peripheral vascular thrombotic issues. Particularly young ages ആയിട്ടുള്ള ആളുകൾ ഒരുപാട് വരുന്നുണ്ട് ഇപ്പം, വിത്ത് ഹൈ സൈറ്റോകിൻ മാർക്കേഴ്സ് ആൻഡ് ത്രോംബോസസ് ഉണ്ട്. റിയലി ടു ബി നമ്മൾ കോഷ്യസ് ആവേണ്ട ഒരു സമയം തന്നെയാണ് ഇപ്പൊ. ഏത് സമയത്തിനേക്കാൾ ഐ ഡോണ്ട് നോ യു റിമെമ്പർ ദർ ഇസ് എ പോലീസ്മാൻ ഇൻ അവർ യൂണിറ്റ് previously. But not the policeman, he is a sub-inspector, SA of police with limb ischemia. I think that ended up in BK, I believe.
Yes, sir.
Yes, sir.
That
We
diagnosis
amputed.
also was missed from the peripheral hospital.
അതെ അതെ, അത് ഓൾ ലിംബ് പോകുന്ന ഒരു സിറ്റുവേഷൻ ഉണ്ടാവുമായിരുന്നു. പിന്നെ നമ്മളത് അങ്ങനെ മെക്കാനിക്കൽ ത്രോംബക്ടമി, മെക്കാനിക്കൽ എന്ന് പറഞ്ഞാൽ ഓപ്പൺ മെക്കാനിക്കൽ ത്രോംബക്ടമിയാണ് ചെയ്തത്. അതുകൊണ്ട് ഓൾ ലിംബ് പോകുന്ന മാറിയിട്ട് BK-ലേക്ക് എത്തിക്കാൻ പറ്റി. അങ്ങനെയുള്ള കാര്യങ്ങൾ ഒരുപാട് എനിവർ ത്രോംബസ് ക്യാൻ ബി ഫോംഡ് എനിവർ എന്നുള്ള ഒരു സിറ്റുവേഷൻ ഉണ്ട് ഇപ്പോൾ. അതുപോലെ PE ഒക്കെ നമ്മള് പിന്നെ വെൽസ് ക്രൈറ്റീരിയ ഒക്കെ പറയുന്നത് എന്ന് വെച്ചാൽ അതിൽ വരുമ്പോൾ നമ്മള് കാലുമ്മൽ ഉണ്ടായിട്ട് അല്ലെങ്കിൽ വേറെ ഏതെങ്കിലും ഒരു പെൽവിക് വെയിനിൽ ഉണ്ടായിട്ട് ത്രോംബസ് ഇളകി വന്നിട്ട് പൾമണറി എംബോളിസ് അടിക്കുക എന്നുള്ളതാണ്. പക്ഷെ എനിക്കൊണ്ട് നമുക്കിപ്പോ ഈ റീസെന്റ് ഉണ്ടായ ഒരു കേസിൽ പോലും
വേറൊരു കേസും കൂടി ഉണ്ടായിരുന്നു, ഒരു ബ്രേക്കിലാറ്ററി ത്രോംബസ്.
കഴിഞ്ഞ ആഴ്ചയിലെ മറ്റൊരാളുണ്ടായിരുന്നു.
അതെ, ഒരു 2 weeks ബാക്ക് ആയിരിക്കും, എന്തായാലും 10 days ബാക്ക് എന്തായാലും.
സൽമാൻ എന്റെ അടുത്ത് പറയുന്നുണ്ടായിരുന്നു.
ലെഫ്റ്റ് ഹാൻഡില് there was discoloration and pain, ലെഫ്റ്റ് പാമിൽ അങ്ങനെയാ പ്രസന്റ് ചെയ്ത പേഷ്യന്റ്. സോ ഫ്രം ബ്രേക്കിയൽ ആർട്ടറി ഫുൾ കംപ്ലീറ്റ്ലി ഒക്ലൂഡഡ് ആയിരുന്നു ത്രോംബസ്. പിന്നെ നമ്മള് ത്രോംബസ് റിമൂവ് ചെയ്തു.
അതായത് ഓപ്പൺ ത്രോംബക്ടമി ചെയ്തത് അതോ ത്രൂ?
അല്ലല്ല, ത്രൂ ആണ് ചെയ്തത്, ഓപ്പൺ അല്ല സർ.
ഓക്കെ. മറ്റേ സാധനത്തിൽ വളരെ എക്സ്റ്റെൻസീവ് ആയിരുന്നു, സ്റ്റാർട്ടിങ് ഫ്രം അയോട്ട, പിന്നെ ഇലിയാക്ക്, കോമൺ ഇലിയാക്ക് ആൻഡ് ദെൻ ഗോയിങ് ഡൗൺ. അതുപോലെ എനിക്ക് തോന്നുന്നു അവർക്ക് they could do up to popliteal and just below popliteal വരെയാണ്. അത് അതിന്റെ അപ്പുറത്തേക്ക് പോകാൻ പറ്റുന്നുണ്ടായിരുന്നില്ല. വെസൽസും കൂടെ ഡാമേജ് ആയിരുന്നു. ഇഷ്യൂ എന്ന് വെച്ചാൽ ഒന്ന് ത്രോംബോട്ടിക് ഇവന്റ്സും ഉണ്ട്, അതിന്റെ ഒപ്പം തന്നെ വെസൽസും there is an endothelial injury also there. രണ്ടും കൂടെ ടുഗദർ ആയിട്ടാണ് വരുന്നത്. അതാണ് വേറൊരു ഇഷ്യൂസ്. അപ്പൊ ഈ പൾമണറി എംബോളിസത്തിന്റെ ഒക്കെ ഒരു കാര്യത്തില് these all emboli directly forming in the pulmonary artery rather than dislodge and come and occlude. അങ്ങനത്തെ ഒരു സാധനമാണ് ഇപ്പൊ എല്ലാ ആൾക്കാർക്കും കാണുന്നത്. അപ്പോ everyone should be careful about that. എനിക്ക് തോന്നുന്നതിനെ കൊണ്ട് എല്ലാ കോവിഡും ഇപ്പൊ നമ്മളാ പിന്നെ ഡൈമറോ അങ്ങനെയുള്ള സാധനങ്ങളൊക്കെ. And also
every കോവിഡിലും ഇപ്പം ICU ഉള്ള പേഷ്യൻസ് മോസ്റ്റ് ഓഫ് ദം PE ഉണ്ട് സർ, മെജോറിറ്റി ഓഫ് ദ പേഷ്യൻസ്. അപ്പൊ ഒരു 10 പേഷ്യന്റ് ഒരു യൂണിറ്റിലുണ്ടെങ്കിൽ ഒരു 8 പേർക്ക് PE ഉണ്ട്.
ചില പേഷ്യൻസ് ആന്റികോയാഗുലേഷനിൽ കിടക്കുമ്പോഴാണ് PE ഉണ്ടാവുന്നതാണ് വേറൊരു സാധനം. That is another challenge. These are the things happening. Anyway, it is good. വേറെ ഒന്നും എനിക്ക് ആഡ് ചെയ്യാനില്ല.